So thanks, Paul, Maurice, for the invitation. So these are the top 5 latest innovations, at least in my view. We saw the landscape of innovation here, and it's pretty broad. So we have leaflet and chordal solutions. We have annuloplasty, both direct and indirect, and we have replacement. So in my view, what are the top 5? And I would say these are all of equal importance. I wouldn't rank any of these, higher than the others, but this would be my top 5. So despite the fact that clip therapy has been around the longest, this still remains the area of greatest innovation, I think, and promise in what we do, because we know so much about it. We know so much about how this therapy works. We've learned that we can put clips in multiple locations, close to 70,000 global implants now. It works well. It's very safe, but there are limitations, right, in terms of complexity of the procedure. Not every valve can be treated. So to address that, we're seeing a lot of new clip designs coming out. So there's innovation here, and the latest, at least from Abbott, is the MitraClip XTR, which has arms that are 3 millimeters longer, and the grippers now have 6 frictional elements instead of 4, and it allows you to grab a lot more tissue. So we had opportunity to do 2 cases so far, and I'll show you. This was our very first case, and this patient had a very, very wide P3 flail gap. So you measure about 17 millimeters, and you'll remember from Everest, any flail gap greater than 10 millimeters was an exclusion. So we're really talking about extreme pathology here, and you can see the degree of flail here and actually some deficient leaflets. So our strategy was kind of a double anchor technique on either side, because we weren't actually able to grab the worst flail section, and with that then bringing a third into the center. So that's how we approached this case, and really got, I think, which was a tremendous result for this type of pathology. There are other strategics in the industry. Edwards has the Pascal device, which is a MitraClip-like device that has independent claspers, which is something that's innovative, and also a kind of spacer in the middle that allows some of the regurgitant orifice to be filled. So a lot of innovation happening in edge to edge, and will continue to occur. The second big area, I think, is chordal replacement. Now, if you look at the surgeon's toolbox, there's annuloplasty, there's replacement, and cords, if you talk to any surgeon, are a major, major part of their toolbox, putting in a Gore-Tex cord. And there have been 2 devices now which have done this through a transapical approach. So I would say this is transcatheter, but not really percutaneous. This is still a surgical procedure. So we have NeoCord and also Harpoon, which both are transapically delivered cords. But there is an effort now to innovate and do transeptal chordal replacement. So NeoCord has a concept for transeptal transfemoral chordal replacement, and another company which you may not have heard of is Pipeline, which has developed a transeptal transfemoral implant. So there's a kind of ventricular anchor, there's a pledgeted Gore-Tex suture, and then there's an adjustment or locking mechanism, and you can put in 1 clip or 1 cord, 2 or 3 cords, as many as you need to treat the segment. This is kind of a close-up. This is actual Gore-Tex manufactured by Gore, and you can see that it looks very similar to a surgical implant. There's a pledgeted Gore-Tex cord and anchor to the ventricular wall. This is an image of an animal study, and you can see here the anterior mitral leaflet, and then the pledget and the cord, and then here's the posterior leaflet. So the third top innovation is direct annuloplasty, and this is another important part of the surgeon's toolbox. And annuloplasty is used in leaflet repair surgery as an adjunctive stabilization therapy for the annulus, but it can also be used as standalone therapy for patients with secondary or functional MR. And translating this into a transfemoral transseptal procedure has unique challenges because of the need to accurately locate the annulus, to be able to place anchors, and then to be able to tension the entire system. So Cardioband was the first device that has successfully achieved this, and you can see that it's a partial band, not a complete band, and it's also flexible, but nonetheless can reduce the mitral annular circumference. Now, the other sort of newer device here is the millipede device, and I'll show you a little video here of how this is done. So this is a complete ring made of nitinol, and it has anchors and what are called sliders that allow you to actuate or to cinch the ring to a smaller diameter. Now this can be collapsed into a transeptal transfemoral delivery system, and you can see here this is a 32 French delivery system that the device can be steered down in the closed position over a mitral valve. And once it's centered under TE guidance, it can be opened. It can also be closed and completely removed at any point, but it can be opened to match the native annulus. And this is done under fluoro and proprietary intracardiac echo imaging. Once the device is positioned over the annulus, each anchor is individually placed into the annulus, and once that's done, there are 8 anchors, then the device can be cinched. And you can cinch it preferentially in the areas of most dilation. As you can see, each individual region of the annulus can be individually seen. Now at this point, if you don't like it, you can actually unscrew the whole thing and take it completely out of the body. It's all pre-assembled, but if you like it, at this point you would release it and it would stay implanted in the heart. So this is what it looks like implanted, and this is a CT scan showing you that it's got a height of about 17 millimeters, and it leaves a lot of room in the atrium for other therapies. This was the very first patient we ever did, and on the left you can see the pre-procedure echo, and on the right you see the millipede iris device with no residual mitral regurgitation. So the fourth innovation is mitral valve replacement, and this is a huge topic, but I think in a nutshell, the attractiveness of this is that it's the only therapy that could really completely eliminate MR and may be sort of more reproducible and have less sort of technical nuance. The sort of other side of the coin is that these are large devices. There's a lot of screening considerations, probably anticoagulation with warfarins required for at least 6 months after these devices, and it is still an operation through a transapical approach. But having said that, there are 2 pivotal trials underway currently in the United States. There's a Summit trial, which looks at the Tendyne device, which is currently under Abbott, and this is randomizing this device, which has an apical tether. That's the unique aspect of this device that allows the device to be repositioned or retrieved, and this will be randomized against surgical mitral valve replacement. And you can see some of the screening issues here. The device has to be able to sit, and for those of you who are not familiar, the main issue really is the left ventricular outflow tract. There has to be enough room there for the valve to sit. So this is kind of what this would look like with the valve going in transapically, kind of a 2D echo view of no MR, and then the final valve here. And Apollo Intrepid trial from Medtronic is currently underway as well, which is a similar device that's transapically delivered, and this will be randomized against surgery as well. So finally, I think the fifth innovation is really combining all of these things that we see the way a surgeon would. And because no repair is perfect, not even a surgeon's repair, we're going to need to have staged and combination therapy. So this has been done in the transcatheter, combining annuloplasty rings with, say, edge-to-edge repair, shown here, or there's a concept of having a docking station and then putting a valve inside that. And then finally, I think you're going to see here in the next year or so some very interesting technology on clip removal to allow patients who've been treated with the clip to have the clip detached or removed to allow subsequent replacement, so that there can be subsequent therapy, and the idea that clip burns bridges, probably that bridge itself will burn. So in conclusion, that's my top 5. Thank you.